Now we move on to the regional soft tissue injuries, and after the head injury we will cover the fascio maxillary injuries. The fascio maxillary injuries are accompanied by injuries to the brain, eyes and the orbit, nose and maxillary sinuses, mouth and the ear, and they must be detected and managed. Cervical spine injury has to be assumed, and secondary injury to spinal cord should be protected. Classification is basically injury through the cranium, orbit and nose and the maxillary sinuses, mouth and ear. So this classification is a basic classification which helps you see everything. The first is a frontal prominence blow, which can cause concussion injuries to the brain, ipsilateral, and counter concussion contralateral. This is the commonest injury when motorcyclists without helmet strike the road divider. The telltale laceration, edema, or depressed fracture must make you suspect head injury and must never be ignored. Second is a blow on the nasion, the horizontal plate of the ethmoid, which is notched between the two orbital plates of the frontal fractures, and this can lead to blood or CSF discharge through nose. These are also called as orbito-ethmoid injuries. Infection has to be prevented, and persistent CSF rhinorrhea may need sealing through a frontal approach. Fifth is a blow on the point of the nose, causing a depressed fracture and needing elevation and immobilization for cosmetic reasons. Sixth is a blow on the zygomatic, which can cause it to fracture from its frontal, temporal and maxillary connection. Then it can get depressed and can cause uniocular diplopia. It needs to be elevated and fixed. The infra-orbital nerve passes through this region and can be injured, and anesthesia to the upper lip must be detected and recorded. The seventh is a blow on the upper jaw, causing it to fracture with the floor of the maxillary sinus, leading to malocclusion of the teeth. It is treatable in a dentulous jaw by interdental wiring. In adentulous jaw, intraosseous wiring or plate fixation may be needed. Eighth is a blow on the symphysis mentae of the lower jaw, causing it to fracture. By a blow on the side of the mandible, the body may be fractured with or without injury to the inferior alveolar nerve. This causes anesthesia to the lower lip, which again must be tested and recorded before you treat, otherwise you will be blamed for it. Interdental or intraosseous wiring or plate fixation is done to reduce and retain these fractures. Nasogastric feeding may become necessary. Covering antibiotic is a must, as these are open or compound fractures which open into the mouth. The fracture can occur at the body ramus junction of the mandible. It can be reduced and plated. The fracture can be in the neck of the mandible, where the head may need to be excised, and there may be a dislocation of the temporomandibular joint, which presents with an open mouth and must be reduced and retained by barrel bandage or gunning splint, followed by physiotherapy. The blow 3 and the blow 4 can cause head injury. Indirectly, fracture through the pterion can occur in blow 3, which injures the middle meningeal artery, causing an extradural clot. Now the first unconsciousness is because of concussion. Then the patient recovers and you are happy. But then you miss the extradural clot which can occur in this injury. And this clot is best evacuated with temporal craniotomy. And the middle meningeal artery is obliterated in the foramen spinosum. Pterion is shown by the red circle here, and it is an area of junction of sphenoid, frontal, temporal and parietal. And it's the weakest portion of the skull likely to break in any blow at the point 3. Posterior cranial fossa fracture causes contusion on mastoid, which is called as the battle sign, and injury to the vestibulocochlear system. Orbit injuries are very special. The lacrimal system and the tear drainage can be affected. The lid can be injured. There can be a black eye. The globe and the cornea and the conjunctiva and the ocular muscles and the optic nerve may be injured. But you can do something about retroocular space occupying lesion or hematoma, which needs to be compressed either by the lateral route or through the frontal orbital plate, which is called as the Naff-Jigger's operation.